back to Poem Peeps. Thank you, as always, for listening. And definitely, Furf and I want to make sure that you like, review, and subscribe to our show on whatever platform you're tuning in to today. Furf, really excited to do a more content-based and guideline-based episode today. We've had a lot of fantastic fellows case files and highlighting educators around the country, but glad to be doing a different type of episode today. How are you doing, Furf?
Good, I'm good. Yeah, I'm saying, variety is the spice of life, and it's always nice to get back to some core content and things that we see every day at the bedside or doing research and sort of staying up to date with everything. So yeah, I'm excited to dive in.
Yeah, couldn't agree more. And turning into today's episode, we've had a number of episodes so far on the show already where we've talked about acute respiratory distress syndrome, or ARDS. We have 3 episodes out already that have ranged from how to titrate PEEP, subphenotypes in ARDS, as well as one on the future of ARDS research. So if you haven't had the chance to listen to those, they're available for you, able to be downloaded and listened to anytime and anywhere that's convenient for you. So really staying up to date on caring for patients with respiratory failure is key for any critical care provider. So we have a few episodes coming out now about the developments in ARDS.
Yeah, absolutely. Something that obviously we see and treat all the time at the bedside, but things are evolving some in the way we're thinking about it. And we want to stay up to date on some of these really practice defining and paradigm shifting papers that have come out in the last year. So we have some updated guidelines from a few societies that we'll go through in a future episode. But today we're talking about a paper that came out last year in the Blue Journal, or AJRCCM, that I think really influenced those guidelines and sort of paved the groundwork for rethinking through this. And it's talking about how we think about and define ARDS with a new, more global definition.
Exactly. And I can't wait to learn more about these updates. And we're very fortunate today to have 2 authors on the paper about the global definition of ARDS to help us with this discussion today. First, I have the honor of introducing Dr. Elizabeth Reviello. Beth is an assistant professor of medicine at Harvard Medical School and a pulmonary critical care physician at Beth Israel Deaconess Medical Center. She is also an affiliate of the HMS Department of Global Health and Social Medicine and an honorary associate professor of emergency medicine and critical care at the University of Rwanda. She is passionate about improving critical care delivery in resource-limited settings and has served on committees for the World Health Organization. Beth, I don't know how you have all the time, but you're also the principal investigator of BREATHE, or the Building Respiratory Support in East Africa through High Flow versus Standard Flow Oxygen Evaluation, which is a large RCT looking at high flow nasal cannula in 5 sites in Kenya, Malawi, as well as Rwanda. Beth, such an honor to have you on. Welcome to Poem Peeps today.
Thank you so much. It's really fun to be here.
Yeah, our pleasure. Next, we have Dr. Theogen Twagirumugabe. Theo is an anesthesiologist and intensivist at the College of Medicine and Health Sciences at the University of Rwanda and is a professor at the University of Rwanda. In addition to his clinical work, he has his PhD in medical sciences. He's a widely successful researcher with over 70 publications in critical care and anesthesia delivery, and is also a lead investigator on the BREATHE initiative that Beth is the principal investigator on. Theo, it's a real honor to have you on the podcast today.
Thank you so much for the invitations.
Absolutely. Absolutely. It's our pleasure. So just before we dive in, our standard disclaimer, as a reminder, this podcast is not meant to be used for specific medical advice, and the views we express today may not reflect the opinions or policies of our respective employers.
Thanks, Furf. And ready to dive into our discussion for today. So in this episode, we'll be talking about the expanding definition of ARDS, and mostly guided by the Blue Journal in 2023 paper that came out, for which you alluded to earlier, and both of our guests today were authors on that. So to start with, Beth, could you tell us a little bit more about how we thought about ARDS before this update and the issues that you all were hoping to help address with your recent paper?
Sure, yeah. So, the 2012 Berlin definition is really what we all use for the last decade. And the goal when that group convened was really to create a syndromic definition that could help people identify and study and treat ARDS. And they were really trying to capture an inflammatory process, but do it in a way that people could then use. And so, as we all know, that included timing within a week of a credible insult, hypoxemia, imaging that was consistent with capillary leak in a diffuse process. And then PEEP was included in that definition as a way of sort of weeding out people who are simply atelectatic, et cetera. And the global definition, in my mind, it is really not so different. The framing and the purpose is the same. It's really trying to have a definition that can help people identify, study, and treat ARDS. But it was really a response to 4 distinct trends or observations in critical care that impacted the definition's ability to capture the population it was meant to capture. So specifically, the increasing use of high flow oxygen, I think both clinically as well as in some research studies, people began to recognize that people on high flow, in fact, had ARDS. High flow provides a huge amount of oxygen, as well as a small amount of PEEP. And both, again, in observation and in research, it was clear that patients who are on high flow, who were then intubated, immediately met the definition for ARDS. And that didn't happen at the time of intubation. It really was occurring prior to intubation. I think the second thing is the expansion of the use of pulse oximetry rather than ABGs and ART lines as a standard. And that, one interesting piece for me is back the ROSE trial, the neuromuscular blockade New England Journal trial in 2019, 10% of those patients were included based on not an ABG, but on pulse oximetry. So this was a trend that's been going on for a while. The third thing was the increasing use of ultrasound at the bedside. And then the fourth was a recognition that the definition really did need to be applicable across the globe, including resource-constrained settings. And part of that was the Kigali ARDS definition that Prof. Teo and I worked on back in 2016. So the increasing use of high flow, the decreasing use of ART lines, the increasing use of ultrasound, and then this recognition for the need for a global definition, I think were the 4 things that really drove the convening of a new group.
Yeah, really interesting clinical trends that are ongoing, and I think continue to evolve. I think the next trend is going to be a lot less ART lines that I already is going there, but I know there's some trials out there already about, do we really need these, and is it worth the time and pain for our patients to place them? So Theo, I was wondering if you could tell us, when you're approaching this, these are sort of the background issues that everyone is thinking about. Do you set sort of specific intentions going into the process? Were there goals that you guys were hoping to achieve in terms of the new places where the guidelines would be used, and how you would think about approaching redefining something that's so central to critical care?
Thank you so much. As Beth very well explained, the rationale behind the new definition of ARDS that includes different criteria that are scientific sounding, but also affordable or accessible to low resource settings. It means that even patients from low resource setting who before the new definition cannot be considered as having ARDS, now can be considered as having ARDS, and then can benefit from some therapeutic intervention that have been proven to improve the outcome of those patients, but also to see if by implementing those therapeutic interventions, if they can really make a difference, because it is not only application of therapeutic intervention that have been tried in different settings that we can conclude that they are effective in our context. So we need to apply those different interventions to see really if they can make a difference in our context of low resource settings, because there are some studies that have shown that different interventions that can be effective in high income countries may not be as effective as in low resource settings. So, and again, also for the improvement of quality of care in the low resource settings, we need also to do some research. And if you do research, you have to have someone or some settings to compare with. But if we have a kind of global definitions, if we try to implement some research or some being observational research or clinical trials, we can also compare ourselves with other settings that may use the same definition. So we need that definition to be able to take care of those patients, but also to conduct some research on ARDS in our contexts, because there may be some differences. Even by knowing the case mix, the factors or the insights that can lead to ARDS are different from those prevailing in high-income countries. Thank you.
Yeah. I mean, such an interesting cyclical problem, right? It's like, if you can't define it, then you can't always treat it, you can't research it, and then you don't know the differences, and then there may be things that are the same, and then things will be different. I was on a panel of people who were talking about ECMO, and someone was talking about how this was in Southeast Asia, about how like a huge component of their people have melioidosis, and I was like, well, I don't know anything about that. Does it change how we're thinking about this? And so have to be able to have these definitions in the first place to set up and research them. So I'm really curious before we get into the content, you guys were both part of this panel of experts that met to update these guidelines. There's a lot of prominent names and leaders on that paper. When you have new guidelines that are coming out like this, they really shape how care is delivered and research is conducted. And so I'm curious about the process of like what it's like to sit down with everybody and talk about this and come up with some new ideas. Any insights that you could share would be really interesting. Theo, I think we can start with you.
So as it is very well described in the articles, there is always an initiative. Colleagues that have had that initiative basing on those different limitation of the Berlin definitions, and they try to gather different researchers and clinicians across the globe, different variety of settings they are working in, so that they can try to see if they can come across and have a common understanding, but also with scientific strong background that may improve the definition of the ARDS so that every single setting can be taken into consideration. So we did several meetings, I don't remember, maybe 6 or so. And then once we have come up with a kind of consensual definitions, we did approach different international critical care societies and anesthesiology society across the globe to gain their input or their comments and take into consideration those different comments to come up with the final definition that has been published.
Yeah, that's an interesting step, to go back, bring it back to the critical care societies. It like adds a lot of, I'm sure, a lot of value. Yeah, Beth, any insights about how the conversations were like with everybody who's contributing?
Yeah, it was such a privilege to be in the room making the sausage, as it were, and it was both messier and more of a privilege than I even understood. That really were the experts in the world who've come up with the evidence that we use, and at the same time, Michael Mathey, who convened the group, did make a huge effort to make it a much more diverse group of people across the world, across various aspects. The 2012, Taylor Thompson, who was part of the Berlin group in 2012, he'll show a picture. It really was a full-on white male mantle in 2012. And this group really was both the experts in the room, but also a much better representation across the globe. So while I had some misgivings about making decisions for the world based on just what a group of people think, I really did see the value in the process, and it was super interesting. And one thing I really took away was the need for a leader or leaders who can listen and frame and re-listen and reframe. And I'll just give an example. I assume a lot of people think it's weird that the definition came out with non-intubated ARDS and resource constrained. But the way that came about was that people like me thought we really needed a definition not dependent on devices that aren't available, that they have to be on high flow or they have to be intubated. But there was a whole set of people that felt extremely strongly that if we just did that across the board, we'd be diluting out the definition, that people on 2 liters of nasal cannula would be ARDS, and that's not what we mean by ARDS. And so it really became the only way we could move forward was to create these categories. And it's unwieldy, but in the end, I actually think it probably was our best way forward given the various concerns. So it was super fun to watch people arguing, discussing, and then coming to some way of moving forward.
Thank you so much, Theo and Beth, for sharing. And yeah, Beth, I feel like Furf and I are probably like, oh, if we could have just been in one of those Zoom meetings to see what's going on. But it seems like it was definitely a meeting of the minds and incorporating, a more diverse panel to really think about this global need and responsibility. So I'm looking forward to delving into the paper a little bit more. And of course, those listening today, we hope that you can definitely take a look and in depth and read the paper. And of course, we'll post it. But to go through it a bit more efficiently, Furf and I thought we could focus on the four major recommendations that were made as an update to the existing Berlin criteria. And you alluded to some of the rationale earlier, Beth, as to why this occurred. But we'll go ahead and start with the recommendation about incorporating SpO2 to FiO2 ratio in the definition. So those listening today likely know we traditionally relied on the P to F ratio less than 300 to define ARDS, and then subsequent levels for severity as far as mild, moderate, and severe. The new global definition includes SpO2 to FiO2 ratios of 315 for diagnosis, less than 235 for moderate ARDS, and less than 148 for severe. And this is largely based on the Kugali modification that is from another paper you were both authors on. But Beth, hoping you could tell us a bit more about the Kugali modification in ARDS diagnosis.
Yeah, sure. So way back quite a few years ago, this was a bit of a brainchild of Prof. Teo and mine. And Rob Fowler at the University of Toronto really was the one that helped us see that it really was a time that he thought people were ready to acknowledge that the current definition really didn't work in resource-constrained setting. And so there's a way in which we use that study to advocate, to sort of point out that with the Berlin definition, 0% of patients in Kigali in this hospital had ARDS. And with our revised definition, about 4% had ARDS, and there was a 50% mortality. So it really mattered. So what we did with that was we literally just said, okay, we don't always have ABGs, so let's use pulse oximetry. We don't always have x-rays, let's use ultrasound, which we do have. And let's take out that PEEP requirement, which is controversial anyway. And that's really how we moved forward with it. And then we used our own definition to come up with some epidemiology around it. Specifically around the SpO2 that you're noting, this is what we did with Kigali, but as you can see in the current global definition, it actually applies across the board. You don't have to be in a resource constrained setting. So I think it reflects what Dave was saying earlier, that more and more, fewer of us are automatically putting in an arterial line. We're going without ABGs in many settings. So I think it's also more universal than that.
Yeah, absolutely. And it can definitely influence care for patients in both settings. And Theo, I'd love to turn to you for that. How do you think that this modification helps us, and generally at the bedside caring for patients with ARDS?
So once you have a definition like the one we have, so you are not going to hesitate or to delay to implement those interventions that can improve the outcome of the patients. And also we can use them through research in our settings that is quite needed. And I hope this new definition can reach a lot of different settings, like in low-income countries, who may also try to use the proposed intervention like lung protective ventilation, high or low PEEP, or some ARDS cases that can meet criteria to be improved with steroids. And we can do some prone positioning, although maybe having some limitation depending on the availability of staff in our settings, but that is something that we can do and monitor the impact of this intervention in our settings, which was not possible with the previous definitions.
Yeah, it's interesting that it's not just expanding the patients are included, but it's also the early diagnosis, right? It really allows you to be making this early on. And then for both clinical area and research, right? If you get diagnosed earlier, you could get in a trial earlier. It may influence the treatments that we can find. And this next question, I think for both of you, I'm curious, there has been a lot of information, and we've been talking about it on the show, some about the racial bias and pulse oximetry testing. A lot of this data is coming out of the United States and really within COVID, because some people were not getting therapy that they should be getting based on the inaccurate SpO2 based on their skin tone. I know you guys mentioned this in the paper, and then you guys thought about it, but any considerations regarding the SpO2 setting recommendation that we should keep in mind given this information that's come out?
Thank you so much. I think it has been said maybe quite a long time ago, but it came up again with COVID-19. Patients have been sent to home with saturation that was wrongly overestimated, and they didn't get the appropriate care. That is why maybe it has surfaced to take a lot of opinion from different leaders, including in medical specialties or journalists. So it is true that in our daily practice, we have different SpO2 or pulse oximeter from different manufacturers. So we do see quite a lot of differences in terms of measurement of the SpO2. And it has been said that those kind of big differences are more important in people with dark skin. Maybe that is why we see them quite often. And I think with the definition that we have, especially those that we incorporating SpO2 over FiO2, we may miss some of the patient. And at this stage, you can't say they are a lot. Maybe they are between 6 and 10%, depending on what has been published so far. But in our settings, like in sub-Saharan Africa, we didn't do a strong study to identify the magnitude of this differences, but definitely there are some patients who may meet the criteria for ARDS who can be missed because of the use of those non-calibrated for dark skin pulse oximeter. Then we hope maybe in the near future we shall have different pulse oximeter that are calibrated to diagnose hypoxemia across different population without taking into consideration the skin tone.
Yeah, fingers crossed. That would be great if we could have devices that were specifically calibrated and designed with this in mind.
Totally agree. I know a lot of people in an active field of research and hoping to see that being implemented in the near future. So the next major recommendation we wanted to discuss was to include patients supported on non-invasive ventilation or high flow nasal cannula at a minimum flow rate of 30 liters per minute. Previously being intubated was a criteria for being diagnosed with ARDS, but this has created a category of non-intubated ARDS patients. And Theo, I was hoping you can walk us through the rationale for creating this new category and including high flow nasal cannula formally in the definition.
I think if we also dive into different recent publication on hypoxemia, especially during COVID pandemic, there are some patients, as they very well mentioned, who may meet the criteria for ARDS if intubated, but who benefited from the treatment with high flow nasocannula oxygen therapy and improved without needing the intubations. And those patients, if this definition is not considered, those patients are not considered as being having ARDS. And I think that is the reason why we have also advocated to incorporate high flow nasocannula with that scientific strong background. But also, if we consider the high flow nasocannula, it is said, or it is true that the patient under high flow nasocannula may have some extent of post a PEEP that can be estimated around 3 to 4 centimeters of water. Maybe that is why some of those patients have improved, but the question that remain unanswered, if we can compare patient with high flow nasocannula with an additional oxygen therapy at NFiO2 like 35%, for example, they cannot be compared with other patients with other oxygen delivery modalities with the same estimated FiO2. So that is something that we need also to work on and see if there is room for comparability. But meanwhile, we can compare X and X, so people on high flow nasocannula to people on high flow nasocannula, instead of comparing with other patients with other oxygen delivery modalities.
Great. Thank you so much, Theo. Appreciate you walking us through that. And I think though we can certainly think and including high flow nasal cannula may allow for earlier diagnosis of ARDS. And Beth, I'm wondering, when you were having the meetings of the minds, did you discuss the implications for this and timing of ARDS and making earlier diagnoses?
Yeah, absolutely. In fact, that was one of the biggest reasons. There are some huge proponents in terms of finding ARDS earlier, largely for research, right? So if you're looking at interventions, you often want to know as early as possible so you know what's going to have an impact. And it was certainly recognized, especially given the practice patterns we have of very often using high flow instead of intubating someone right away, that would be a way to get at sick patients who truly have ARDS, but earlier in their course. And if we exclude high flow, as we had been previously, we'd automatically be missing them in their earliest stages of ARDS.
Yeah, it's so interesting because it totally makes sense. You see these people on high flow, they clearly have ARDS. But then it's also interesting to think about, and we'll get into this in our next episode of the guidelines, that, our mainstay of ARDS has been low tidal volume ventilation, which you by definition can't do on high flow. So then are they, so many, a whole new basket of worms. There's always more interesting things to talk about in medicine. The next major change we wanted to discuss, you alluded to already, but was thinking about the imaging criteria for ARDS. Classically, ARDS is said to have include bilateral opacities, and this has been defined by chest radiography or CT. However, ultrasound, POCUS, more ubiquitous than ever, both in resource or limited settings, but also in, resource-rich settings. It's just we're learning to use this better, and hopefully everyone listening is getting great learning on lung ultrasound techniques. So, Beth, can you tell us about this definition and how it helps update our understanding of ARDS?
Yeah, absolutely. And this was a fascinating one in the group as well, I would say. That we brought it in the perspective of resource constrained settings. And I, in fact, learned lung ultrasound from Prof. Teo's residents. They were all better than I was, and they used it a lot when I was there years ago. But as you say, it's used by everyone. And I think anyone who uses lung ultrasound clinically can speak to the fact that while it does require someone who knows what they're doing, and it does require looking at all the lung fields, it's so much more specific. So if you look at a chest x-ray, it can be very hard to tell between an effusion and an opacity, whereas on lung ultrasound, it's very clear between an effusion and an opacity. And so there are clear advantages, frankly, to ultrasound. And historically, there's clear recognition in the ARDS group that chest x-ray and the inter-rater reliability is actually extremely poor with chest x-rays. So in my mind, ultrasound is at least equivalent, but in fact better than chest x-ray. Among the group, there was a fairly clear divide between people who had trained in an era when ultrasound is used a lot at the bedside, and for those who are in the group who did not have that as part of their training when they trained. And so it really became people who had experience with it, I think, sort of fighting to say, look, we really do think this is a valid modality. And for people who don't use it at the bedside currently and didn't train on it, for them sort of coming to recognize through various studies and also people's experience that, yes, in fact, this makes sense, that there's no reason why an imperfect chest x-ray and an imperfect lung ultrasound, both of those can be considered as part of the definition.
Yeah, I think such a great point. And I think, as you noted, Beth, right, we need to make sure that there's great educators that can teach ultrasound for those that are able to incorporate this going forward. So I think that's really interesting. Finally, we wanted to talk about an overarching change that some of these prior updates play into as well. And this is going to be the addition of a modified definition of ARDS for resource-limited settings. We've touched about this a couple of times already, but specifically with the inclusion of SpO2. And Theo, can you tell us a little bit more about these modified criteria and what they include specifically?
So as you know that in previous definition of the ARDS, they are just relying on PaO2, which means that they have to use the arterial blood gas, which is not available in every settings in our low income settings. But there are also some increasing evidence that SpO2 over FiO2 and PaO2 over FiO2, they are very well correlated. There is a strong correlation between SpO2 over FiO2 and PaO2 over FiO2, as long as the SpO2 is less or equal to 97%. So there's a study that has been published, I think, in CHEST in 2007 by recent colleagues that quite show that there is a very strong correlation between SpO2 over FiO2 and PaO2 over FiO2. This means that in our settings, almost in every single accident and emergency department or ICU and HD, and even in some internal medicine or surgical wards, the pulse oximeter is available, irrespective maybe some limitation that we have mentioned a little bit above, but that is a tool that is readily available on bedside, and the FiO2 we can try to calculate depending on the oxygen delivery devices, whether in intubation or other non-invasive oxygen delivery devices. And this can also be a very good and accessible definition in our settings. And I think it has been proven even in some definition of the ARDS by some research in high-income countries. So I think that's a very good input from this new definition that can also be used in our settings with a strong confidence that we have a very scientifically sounding definition.
It's clearly so important to be able to have this separate definition. And I Beth, you kind of beat me to the punch already. You talked about the fact that there are really three definitions, right? There's intubated, non-intubated, and this resource limited. And certainly they have pointed out well how it's helping us expand and make these diagnoses when we wouldn't be able to previously. I'm curious the implications this has had for you caring for patients, or the ones that you've seen at the bedside, for the people who are not on high flow, are on other oxygen delivery devices, and are now you're thinking and trying to make a diagnosis of ARDS, sort of outside parameters that we've done before. Like, how has it influenced your thinking, and how do you think it's influenced their care?
Yeah, I do. I'd like to think it's even more important. And since we have so few things that we know actually work for ARDS, one could argue, clinically so far, why does it matter? And, and there's a sense that it doesn't change things. And I will say, back when we did the Kigali study, Prof. Teo and I, we did a little sub-study that we didn't publish, and we looked at the ventilator settings for the subset that were on ventilators. And I'll tell you that those patients who did not have diagnosable ARDS at that time very largely were on low tidal volume ventilation at rates much higher than some of the studies that are done in US and Europe. So you could argue that people are already providing the right care for those patients. But I nonetheless think it's a platform. And once you start thinking of someone as ARDS rather than just a little hypoxemia, I do think, one, you're more aware of the severity and the potential for them to escalate. But also, there are things that we can do. So for instance, when they do get intubated, making sure they have low tidal, we do think, conservative fluids can reduce their time on the ventilator. And as Prof. Teo said, there are constraints, but we certainly can prone people. So I do think it matters clinically to sort of raise the suspicion of clinicians and get our minds thinking towards the specific things we can do for those patients.
Yeah, totally. And terminology is so important for us. We're at bedside. We're now talking about ARDS. This is severe. This is something we have to, be addressing and reevaluating frequently. Well, this has been a fantastic discussion that changes. Certainly a large paradigm shift in how we're thinking about ARDS. And I hope all our listeners are now, if they hadn't been aware of this, will be seeing their patients who don't have an A line and saying, I think I can make this diagnosis now. A lot of positive directions this has taken us in, but as in the case with medicine as always, that also raises a bunch of new questions. So I was hoping you both could tell us what you see as the next steps now that we have these definitions. Where do we move forward in our clinical care and research to keep advancing the field? Theo, we can start with you.
I think in our settings, I hope that many settings will adopt these definitions so that they can start to improve the patient care by adopting those different therapeutic interventions that have proven to be successful. But also, we hope that with this definition, with different types of definition, we're going to have some research to see if they can be validated or can be improved, as we mentioned, like for the SpO2 in patient with dark skin, if we can try to see if the SpO2 of 97% is the optimal cutoff. So that can be a next move. But also, as you have seen the definition for the low income settings, we don't consider any minimum flow of oxygen. I think that is something that need also to be explored so that we can see if there is a strict minimum of oxygen flow that can be used so that we can improve the definition. And of course, the next move, I think that if there is any therapeutic information, any new drug, any new intervention that can be envisaged for the management of the ARDS patient from low-income settings will not be excluded because that definition can also be used.
Yeah, that's great. Beth, in your mind, next steps as well, in addition to those, I'm sure?
Yeah. I mean, for me, the big elephant in the room in this process was the subphenotyping of ARDS and the fact that really what we want is a definition that actually finds inflammatory ARDS pathophysiologically, right? And I think everyone in the room agreed that we weren't far enough along yet in that work to get there. Which that to me is when we really need a new definition, is when we can do that. And Carolyn Calfee's work and Noala Meyer's work, that's where I see the future going. And what's nice about this definition, though, the global definition, is I think it's critical in that work that populations across the world are in that research around subphenotyping. We need to make sure that we've got a diverse population as we go about figuring out how to understand inflammatory and non-inflammatory. And with this definition, it makes it possible for places like where we work in Rwanda to be included in that subphenotyping work so that it's not, once again, a piece of research that's done in a very limited part of the globe.
Well, thank you so much, Beth, for adding that. And we've had such a fantastic discussion with you both today and really appreciate your time. As those listening today, you know that Furf and I always like to end with a teaching point. So Furf, I will start with you. What is one thing that you want listeners to remember from today's episode?
Yeah, and I think that Theo and Beth both alluded to it and said it, thinking about ARDS as the overarching of what are we really trying to diagnose here, and that there's these new buckets of intubated, non-intubated, and resource limited, and the definitions can be helpful and make sense, but really what the definitions are trying to get at is that this is a disease that we can think about clinically is occurring in our patients, no matter what kind of care we've chosen to support them with currently. And that's what we're trying to get down to. That's the truth of the matter. And so these definitions are trying to help us make that diagnosis. And you can see a patient without an A-line who's on low flow oxygen device, but still think to yourself, should I be putting them in that bucket?
Great. Theo, what about you?
Although we have different definitions, we have one for low resource settings, but this is not just something that we have to use for the low resource setting. If resources are available, we can also adopt the definition for the high income settings. But it's a very good one. I think that is the move, I can say, if the scientific communities would embrace that approach, so that if there is something to define or if there is a therapeutic intervention to initiate, try to do not leave behind patients from low income settings. That is what I have learned from these global definitions.
Great, that's a perfect point. And Beth, what about you?
Yeah, I think my takeaway would be a broader point about, and it's one that Prof. Teo has really already mentioned, which is the power of research in the pursuit of global health equity, that the evidence that we generate in high resource settings, we already know particularly from sepsis literature as well as other literature, that it actually doesn't apply, and that we need to be doing resources in the context in which we're going to apply them. And I just a plug for people who are interested in health equity across the globe, that research is a critical pathway for pursuing that.
Great. Thank you so much, Beth. And I forgot to add mine, but I think mine is, I definitely agree with the three of you. Beth, what you alluded to earlier today, right? A lot of different people around the globe and how to incorporate a new definition based on other modalities, as you mentioned, high flow, lack of ABG, so incorporating more pulse oximetry and the ubiquitous use of ultrasound. So I think that was just a great discussion that we've had so far today, and just really appreciate both of you joining us.
Yeah. Thanks for coming so much for coming on the show. Thank you all for listening. Our next episode will be out in 2 weeks, so make sure you tune in. This episode was written, produced, edited by myself and Christina Montemayor. Original music by Eric Rogers, and we'll see you next time.